where you will put the temporal bone holder, and a round tray is there, a round bowl is there. That bowl is for water only. So keep that bowl for the water, for irrigation fluid. And I think all of you have the requisite instruments with you. The requisite instruments, requisite drill, bars.
These prizes will be given next year during our annual conference. Every year we find that somehow one or the other is absent to take this prize from our esteemed, those are the guests those who are there who are distributing the prizes. So please be there. Please be there in the next conference, everyone, because conferences are also very important. And for today, the first and second, they from the part of our association, that we will be gifting them horoscope for your daily use, and this is a declaration. So, but this is given to take a promise from you that you will be there in the next annual conference and receive your prizes from there. Okay? Thank you.
Thank you, sir. That was an excellent announcement. So I think the first session is already over. I request the contestants of the second session to kindly take their seats. They have to start their work by 10 a.m. sharp. Just 2-3 minutes remaining for 10 a.m.
And this is the temporal bone weight specimen, left side. This is the superior side, this is the inferior side, this is the anterior side, this is the posterior side. Can you see? Suction canal, suction canal. Suction canal, suction canal. Foot switch, foot switch. কোন দিকে? The drilling is the supramaster crest region. Huh? This line is the supramaster crest, or called as linea temporalis, or inferior temporal line. All are same. And it indicates the lower border of the middle cranial fossa. And another drilling I will do. Along the tangential to the posterior meatal wall. Here the posterior meatal wall is not stiff. Here the posterior meatal wall is slightly bent and slant. These are the two cut lines by which the dissection is starting. Okay, ডাকো জুম আউট আমি করতে হবে। And here is the junction of the two, and at the junction of the two line, I will try to remove the mastoid cortex so that I will gain entry into the antrum. Good.
Dr. Mukherjee,
Yeah.
can you show the students the spine of Henley in this particular case? That is a very important landmark, but I think that is very small in this particular case.
Here in this particular specimen,
Yes.
the Henley spine is not so prominent.
Not so prominent.
But likely it is my sucker point, which indicates the position
And the cribriform area, can you show the cribriform area where lies the mastoid antrum?
The cribriform area already I have drilled.
Yes, already drilled.
Drilled. That is the call as.
Is there any significance that the spine of Henley is very small in this particular patient?
In this particular patient, spine of Henley is not so prominent.
Yes.
But there is no clinical significance.
But I have experienced that that if the spine of Henley is very thin or very small, then the mastoid antrum is usually small. So when the mastoid antrum is very developed, then the cribriform area and the spine of Henley also is very big. So when I think I have in my experience I have so that when the spine of Henley is very small, so likely the antrum is not so big. Okay.
And in the spine of Henley should be preserved at any cost,
Yes, yes.
but for the landmark, and still I get another landmark, the spine of Henley should be preserved, and it will also be preserved for revision surgery if requires. Acts as a landmark.
Please centralize the picture. Yes, yes, yes. Okay now. Okay. All that is okay. This is not focus is not clear.
Focus is not clear.
Some bit hazy.
না না এটা ফাইন ফোকাসটা এখানে এটা ফাইন ফোকাস না না মাইক্রো
Yes, it is now okay. Okay. Almost good. Very good. Yes. So what is the magnifications you are working, sir?
magnification I am using 6 times magnification.
6, okay.
6. Bone is sclerotic. The Messian's triangle is different.
Yes.
I have demarcated two lines, one is along the supramastoid crest and another is tangential to the posterior metal wall. But the Messian's triangle is different in this form. The supramastoid crest and posterior superior metal wall, another wall, and tangential line drawn to the posterior margin which will carve this supramastoid crest. This is the Messian's triangle, and that is the triangle of attack.
So, sir, this is likely a very sclerotic mastoid.
Very sclerotic mastoid.
Yes.
The posterior metal wall is fainting.
Yes.
It is not like usual cases. So, when it is a sclerotic mastoid, so I will apprehend that the dura, middle cranial fossa dura is low lying and the lateral sinus will be forward lying.
Yes. So, this is very contracted antrum. In this case, so doing a cortical mastoidectomy or opening the mastoid is very difficult, I think.
Sir, in these sort of situations, what are the precautions you would like to suggest our juniors that they should take in mind prior dealing with a sclerotic antrum?
You should be very much cautious whether if it is a forward lying sinus, then the blackish hue will be visible posteriorly. At that time, you have to change your bar so that it will not injure the lateral sinus, and as well as the low-lying dura may be injured, so you will take precaution.
So smaller size bar and the speed of the drill.
And the speed of the drill also should be regulated also. পিকচারটা দেখা যাচ্ছে During drilling also, I am trying to socialize the margin.
Sir, please centralize the field, sir. We cannot see the entire field. The triangle of attack. Yes, sir. Right now it's center. But I think, sir, if you use a bit shorter magnification, that will be helpful because we cannot see the external auditory canal. That will visualization of the external auditory canal may help us to orient.
देखो देखो 0.6 से আছে তো
Yes, sir. Yes, sir. This is the view actually we want.
This is the 4.4 magnification. Yes, no problem. কি ডক্টর জানা
Yes, sir. Yes, sir.
Is it okay?
It's quite fine, sir.
না এই তো আমার স্ক্রিন থেকে সরে যাবে
Someone please adjust the fine focusing.
posterior metal wall here, it is completely slant. আর বার আছে একটু ছোট সাইজ বার হ্যাঁ দাও বার করো ওই গো একশো তো ইচ্ছে না No?
Sir, is it the Dura?
Likely.
Yes, it is likely the Dura.
Can you
Yes, yes,
see
yes.
this is a soft tissue structure here?
Yes, yes, yes.
Likely maybe Dura.
Yes, yes.
I have changed my drill bar.
Yes.
Initially it was a point 6 times 6. Now it is 4. It has been changed. And in a living body, when you are live surgery, before reaching the dura, you will get some bleeding.
And the most important point for the juniors that it's not a offense to expose the Dura, but it's very important to detect that Dura.
Yes.
If you cannot identify, like sir did with the suction tip, by elevated the Dura, that identification is very important. Otherwise, you will be in the cranium.
And
In my earlier days, I have one opened the dura, and I thought this is the sac of the cholesterol sac, and I opened it, and the patients developed meningitis, focal meningitis in the later period.
It is very common mistake.
Very common mistake. Sir, I think you can do more anteriorly, more anteriorly.
Yes, also
Yes. Because here, there maybe you can find the lateral sinus. I think if we do the more anteriorly, near just posterior to the spine of Henley, towards the root of the zygoma. Yes.
but chance of injury to the facial nerve also.
Yes, that's true.
Contracted mascot, antivirus, sigmoid sinus.
So, any question from the audience?
I think this session should be an interactive one. So the juniors, please feel free to interrupt sir at any point of time. If you have any question, please stand up. Feel free. No question is awkward to us. Whatever sort of question is in your mind, please express that. Because this is the platform where you should clear your doubts so that you will not be in awkward situations during your live surgical scenarios.
Quick.
Okay.
Sir, we can see that as because the antrum is contracted, so the shape of the antrum is almost like a well, is a narrow one.
Yeah.
So, will you think that drilling in sort of a bit anterior location will be helpful so that we can get a much wider area towards the root of the zygoma that Janas has said? Because the more you go deeper, the area will be more narrower. So, it will be again difficult to visualize.
Now at that time socialization is needed. You have to do the socialization simultaneously. দেখি আর কাটিং বোর্ডটা একটু চেঞ্জ করে দাও। এটা কাটছে না, ওই আগেরটা দাও। দাও। বলা যায় এনি প্রবলেম? ওইটা বারটা দিচ্ছেন না,
Speed.
আর বারটা বড় ছিল।
Increase the speed of the bar, speed of drill. Okay. So it is always very a difficult situation when the mastoid is very contracted. Even I have some experience that I have started to drilling in the postural approach, and now without finding the antrum, I have started again from the attic. That is the best options. Inside out. So when you are when you are not entering the antrum or not finding antrum, you always feel very sacky. I have done mastodectomy about 2000 or 4000 like that. Still I find very sacky in case of contracted antrum when I am doing the posterior approach. I am not sure whether I am entering into the dura or into the lateral sinus. Or in the antrum, in various contracted antrum, if you go anteriorly, as sir told, you may injure directly into the facial nerve.
Yes, what sir said, I think this is the pulse of wisdom, that whenever you had a contracted antrum, you don't know, or you are in doubt that you may hit the dura or you may hit the sigmoid, straight away go for the inside out approach. When you have the retraction pocket or something like the pathology in front of your view, start drilling from that area and trace the disease backwards, so that you will not damage any vital structures, and safely you can drill out the pathology according to its pathway.
But Dr. Das, inside out technique will definitely lower the
Yes, but
breathe.
it has its disadvantage of simultaneously lowering the canal, because by doing that procedure, inadvertently you are lowering the canal. That is the disadvantage of the procedure. But even if the disease is limited, you can always reconstruct the canal.
Yeah.
Inside out technique is much more require much more skill and practice, because you can injure the choroidal nerve, you can injure the tympanic membrane itself, or even you can injure the facial nerve if your drill slips into the facial canal. So skill is required.
So taking the word from Jana sir, that regarding the facial nerve, the advantage of inside out technique is that the ossicles are protecting the facial nerve like a mother protecting her son. So whatever the pathology, you should really address it lateral to the ossicles, then you remove the ossicles very cautiously, and then address the rest of the disease.
No?
This is the ideal bone for temporal dissection during the workshop. বলো কি বলো।
So very important question asked from one of the junior colleagues, that even if there is inadvertent exposure of the dura and sigmoid sinus, what are the maneuvers that one should do to protect it? So first, if we come to the dura, Dr. Jana will light into it.
So when you enter into open the dura, so the structure usually is a little white and looking like sac. But you can, in that case, or if you can just take a 5 cc or 10 cc syringe, and you can just put it and you can see whether some fluid is coming or not. Even
No
in case
comment.
of, but if you injure the dura, that is sometimes problems, but it is not very problematic. Patients may develop a focal meningitis, as I have seen in one or two cases, but that can be managed easily. And in case of bleeding from the lateral sinus, any bleeding, any severe bleeding can be controlled by giving only pressures. So if you give a pressures with some cotton or gel foam, soaked in adrenaline, or sometimes this can be controlled. So usually in my case, I have done so many cases where I have injured the lateral sinus, and then I do usually when there is severe bleeding, I stop the doing from that side, and I again going other side where there is no dura or no lateral sinus, and I started dealing from it. Like in this case, if I open the lateral sinus, so I will also start again from the inside out, because I will give pressures to this area, and when I will do from the inside out, in that case it will be, I seen there after 10 minutes it will be okay, no problem.
Just
Hello,
few,
hello.
just, hello, sir.
Thank you, Dr. Jana. So I must say that we are all bit lucky that this temporal bone is a very sclerosed one, because this is a situation we all don't want to have in the OT table, and when we have really we face many
I am
problems.
just telling Debu that this is not an ideal temporal for what the workshop is.
Yeah, it may not. It may not
is
be an
ideal temporal.
It may not be
It
an
is so
ideal.
much
work-
contracted.
Yeah. So we can learn so much from this, and I think in a similar case, I think the best strategy is not to search for the mastoid antrum, but to delineate the sinus plate and the tegment plate.
Very right,
at the
very
first.
right.
After doing a proper what we call nowadays is a triangle of attack, and if you just follow this case, as he is drilling more and more, and he is approaching the tegment plate, the antrum is not that contracted as it was we are initially finding, isn't it? And
Dr. Mukherjee, sir.
And secondly, it will require a lot
I
of.
think you are also increasing the lateral sinus here.
Yeah.
Yes, this is also the lateral sinus.
Yeah, also the lateral sinus, the sinus
Yes.
plate.
Yes,
we are
sir,
also
this is the sinus
exposing.
plate.
And the actually, the nowadays the strategy for entering the antrum is delineate the tegment plate and the.
So I think this is a very, very important bone for the juniors. So
Just a minute, Dr. Jana. And if a careful drilling is done just below the tegment plate at the posterior root of the zygoma, we ultimately reach a cell which may be very small in contracted material and which may be larger in other cases. And when we reach this cell and the lateral semicircular canal, identify the
তমাল দা স্যারের মাইক্রোফোনটা দেখো, তমাল দা ওই মাইক্রোফোনটা কাজ করছে না, মুখার্জি স্যারের আওয়াজটা কেটে কেটে যাচ্ছে।
antrum is above the level of the spine of Henle. This is something that we fail to understand. We drill just behind the spine of Henle or below the spine of Henle. And that is very dangerous because if we go deep in that place, we'll definitely hit the pyramidal turn. So it is above the level of the spine of Henle. That is a very, very good landmark. And please grow a habit that until you reach the mastoid antrum, don't destroy the spine of Henle. Because in small cases, just by a touch of the drill, it goes off. You have to be very careful on that. And now see how the antrum is so anterior. Again, antrum is so anterior. And unless you identify the lateral semicircular dome of the lateral semicircular canal, don't say I am in the antrum. Because if you are mistakenly find a cavity and think it an antrum, you can injure many things. Sorry to interrupt. Subrata, please continue. Thank you.
So again, some of the pearls of wisdom from Mukherjee sir. So the nutshell is not to go to identify the aditas initially. Try to identify the lateral semicircular canal, tegmen, and the lateral sinus. and automatically if you widen the area, you will ultimately land up into the Adidas, and so on. So as we discussed earlier that it's a bit anterior drilling may enlarge the area. That is what sir is doing now. That is drilling in the anterior part that is towards the root of the zygoma. So that will widen the area, and so the identification will be much more easier.
আচ্ছা
তমালদা স্যারের মাইক্রোফোনটা কাজ করছে না।
হ্যালো 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 ওকে
মুখার্জি স্যারের মানে আমাদের
ওইটা।
ডিসেকশন সুব্রত স্যারের মাইক্রোফোনটা কাজ করছে না।
আচ্ছা in this case I want to mention one thing. I am Professor Hajra. Dr. Jana, may I speak something?
Yes, yes, definitely.
In this case, particularly when there is the confusion of getting the mastoid antrum and there is consistent mastoid, in a journal 2007 and in BMJ there is an article, and I showed always to the student the spinopelli is the landmark, not the Magnus triangle. If you
Yes,
go
yes, yes.
vertically downwards toward the spinopelli, you will get the Adidas antrum, and it is a definite guideline.
Yes,
So
yes, yes.
vertically downwards, I can show the journal, and I follow. Probably it is from the Mishram Lucknow, and another from that I used to go directly if this such thing happen, and there is sclerotic mastoid, to search the go directly and sharply directly vertically towards the deep depth. You will get the Adidas antrum, and then if the pathology is seen, then we go towards the mastoid antrum. If the pathology is not seen, then we mean the window, making a window at the antrum, we will get some guideline about the pathology of the antrum also. So here also, from that Adidas antrum you go behind, but take care not to injure the ossicle, that is the short pressure of the incus, as well as the damage to the ossicle. So gradually,
That is the lateral sinus. So that is the lateral sinus, I think.
দেবতাকে দিয়ে দিই একটা জিনিস শুনুন আসছেন শুনুন
Here also important is the depth. We know the depth is about 1.5 centimeter, and also we can see the tympanic membrane annulus. So the antrum is always below the very contracted antrum. It is 1.5 centimeter. So more drilling is required here. Posterior কোথায় যাচ্ছে মনে হচ্ছে
Sir, do you think that is leading towards mastoid antrum? Adidas, that the direction of drilling that you are doing?
I am just socializing the cavity.
So what we perceive that may be the pre-sigmoid dura or the dura.
Maybe.
Mukherjee sir, Dipankar sir,
হ্যাঁ বলো
Hello.
what is your opinion, sir? Isn't it too inferior?
yeah.
That should not be the location of the antrum. I think it should be somehow anteriorly. Yes, that should be. You should.
হতে পারে তো বলা যায় না।
রিওরিয়েন্ট করতে বলো
Sir, will you please reorient the audience, superior, inferior, roof and floor of the external canal so that the audience can orient?
আমি বলেছি
We can see the drum, we can see the tympanic membrane. This is the right ear,
No, this is the left ear.
this is the left ear. Okay. So, sir, you are making the canal down.
No. More anteriorly I am going.
Sir, what if what we have discussed in this point of time, as it is being difficult to identify the antrum, will you go and inside out so that we can see the rest of the ossicles and that?
I am trying to again explore the astroantrum from posterior side.
Yes. I think this is the right area to find the antrum. Just posterior to the spine of Henley. And
না above the spine of Henley, posterior and above
Yes.
the spine of Henley.
posterior anteriorly, okay. But in this case also there is a difficulty that you can land into the ossicles. You can land into directly into the ossicular chain. Very conducted downturn. I think anteriorly we can see some cells.
Yeah.
Yes, this is based anteriorly, anterosuperiorly. We can see some cells. Yes, that is the area of antrum.
তুমি ঠিক বলেছো ওর এটা সেল শিকার দিলেই ভালো এটা একটু অ্যাটিক শিকার দিলেই ভালো করতো
You can do more anterosuperiorly. Yes, this reed should be drilled out. Yes, here you will find. Yes. Again,
কত দূরে কাজ করছে বুঝতে হবে
yes, now the picture is very well. ওটা উপরে বনটাকে ড্রিল করতে হবে, হ্যাঁ। Yes.
So, taking the previous question of how to deal with the dural injury. So, dura will warn you by giving a sort of bleeding prior getting it damaged. So if you can identify that, go ahead with bipolar. It will, most of the time it will be tackled by the bipolar diathermy. Even if you have damaged the dura and somehow there is CSF coming, then you have to immediately repair that defect, like we do in a CSF leak in a multi-layer manner. First you can give a cartilage or fascia, whatever, but you need to repair that leak. And even if there is a much larger area of the defect that is not leaking, one should always reinforce the area with a piece of cartilage, because later on, if a wider area of the dura get exposed in a long time, that may herniate and may develop into a brain fungus, or what you can say as meningocele. Regarding the sigmoid sinus injury that Dr. Janas has said that mere packing with Abgel or cotton ball, be very careful regarding the cotton ball, because because it bleeds too much and you press too hard, it may go inside and it will be very difficult to retrieve the cotton ball. So try to press the sigmoid with the Abgels, and if you have the luxury of having the bone wax, press it with the bone wax. Within no point of time it will control. So these are the some of the practical tips to control the sigmoid and the dural injuries.
Can you
That
see,
is-
I am within the antrum. Likely, this is the antrum. Can you see? Hello, Dr. Jana.
Hello.
Yes, sir, we can hear you.
Yes.
Here, as it is a contracted mastoid,
Yes, definitely.
I am within the mastoid.
Ah.
I can see that this is the antrum.
So antrum, you can give a probe in the antrum
Here,
and show me the Adidas, because when you are entering the antrum, Adidas is the most important thing. When you go to the Adidas, then I am sure that it is the antrum.
Okay.
Because the lateral semicircular canal sometimes is very difficult to see. So until you show the Adidas,
This is the tegmen plate,
yes, that is the tegmen plate.
tegmen antri.
Yes.
And tegmen antri, I am going towards anteriorly
Yes.
to remove the epitympanic wall.
But can you probe? Can you give a probe? So show me the.
I
Show me
will
the.
probe it. I will probe it. In the living body, definitely you should not probe. But in this particular case, for demonstration purpose, I can introduce the probe.
So the juniors want to know that they know that three landmarks of the mastoid antrum are the lateral semicircular canal, the fossa inquitis, and the aditas. The aditas has not yet visualized. As you have said that we are in the mastoid antrum. Can you point out the landmarks that where could be the location of the fossa inquitis and the lateral semicircular canal?
Right. This is Adidas. Can you see?
Yes, sir. We can.
We can appreciate.
Yes.
But I
Now
have to
that is
remove,
the.
I have to remove this wall. I have to remove this wall. All possible types of injury is occurring here as because it is sclerotic mastoid. I am in between the superior tympanic wall.
But I am not still convinced that you are have entered in the antrum.
Yeah, yeah.
I think it is much more deeper.
No, no, no. Wait a little bit.
Because the Adidas will lead to the epitympanum, and we are again above the level of tympanic membrane. In my experience, I've seen the level of the annulus and the tympanic membrane is very important for locating the antrum.
Debu,
Dr. Jana, this is the lateral semicircular canal. Here you can see.
Yes, it is a very small antrum. I am seeing this is the antrum and going
This
to
is
the
the
aditus.
lateral semicircular canal.
Yes.
This one is the lateral semicircular canal, and this one is the aditus. Can you see?
Yes.
Okay. Right.
Posterior there is opening. It is the opening of the semicircular canal.
Likely.
Likely. It is a posterior semicircular canal.
That is the posterior semicircular canal.
So you can see the opening where there is a elliptical opening. This is like the posterior semicircular canal.
So,
And above it the lateral semicircular canal.
as the semicircular canal is
So
being,
practically in this particular case, antrum is almost absent. Only there is some adidas. Practically there is no antrum. So
very much contracted.
very much contracted. And in my opinion, in this case, we have to opening the antrum. We will land definitely in dangerous.
Yeah.
So better to postpone this approach and go for the inside approach.
Dr. Jana,
Yes.
just from the textbook,
Yes.
that mastoid antrum is the only constant mastoid hair cell that is
Yes.
present.
Yes. Yes. Yes.
So it
Definitely.
can never be absent.
Yes. It is very small here. Very very small. Absolutely.
maybe very
Yes,
small.
Yes. 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 Sure.
Very much contracted, that may be. So, the injury of durameter as well as the injury of the lateral sinus has occurred. This is the epitympanotomy.
But in the epitympan we can see the ossicle. This is only the head of the malleus.
Okay, then that will be visible.
I think you are not still in the antrum. Because when you are going the antrum and adidas, you can see the ossicular chain.
देखिए, कोबरा देखिए। It is freely passing. Can you see? It should not be done in the living body, but for demonstration, I am showing that the tympanic membrane
You can elevate the tympanic membrane from the annulus.
yeah,
And now we can
This is the lateral semicircular canal. Definitely bulging is there.
you can elevate the tympanic membrane from the annulus, and
Yeah.
from the attic we can also see the adductus and antrum.
देखिए elevator दो elevator दो না এটা দিয়ে হবে ঠিক আছে Dr. Jana. Dr.
Yes,
Jana,
I am with you.
can you see?
Yes. Ah.
This is the tip of the probe, but it will destroy ossicular chain.
But one word of caution for the juniors that never probe that adductus like.
Should not be done.
Yes, sir, yes.
It
Like
should
you
not be done in
pointed.
the living body.
Yes. Because that will.
For demonstration, I am seeing this is the lateral semicircular canal. This is the lateral semicircular canal. This is the posterior semicircular canal. The posterior semicircular canal has been opened here. Can you see the posterior?
Yes, sir. We
semicircular-
can see that.
So,
That is the non-ampulated end of the posterior semicircular canal.
so how can you say that it is not in the antrum? Definitely, the antrum is a contracted one here.
Yes, sir. We are in the antrum. Right now
are
we
in the
can
antrum.
appreciate the dimensions of the antrum.
Wait. And likely the ossicular chain is absent. Ossicular chain is absent, so the head of the malleus and the body of the incus is not available in the epitympanum.
Now you are heading towards the epitympanum.
The epitympanum lateral wall I am removing. The epitympanum or attic lateral wall I am removing. Can you see? Towards the root of the zygoma I am going. This is known as extended cortical mastoidectomy. Extended cortical mastoidectomy. Here also chance of injury to the dura mater is there. In the roof of the tegmen antri, in the roof of the tegmen tympani, there may be injury to the dura mater also.
So one question from the audience, that when you are drilling in the epitympanum, is it from the outside in or in or out? What
No,
should be the
still-
direction of drilling?
No, still I am outside in.
Okay.
So the landmark where you should stop in this approach is that you should see the head of the malleus. In the anterior epitympanum, you can see the head of the malleus where you should stop.
Definitely in the head of the malleus, but in front of the head of the malleus, you may get the cog.
I think that posteriorly the opening of some cells. So if you can drill this area, you can go into the antrum. Yes, some cells are seen here.
Here should be the head of the malleus and the body of the incus.
So what is the size of the bar you are using now?
This is 3 size, 3 mm.
3 mm. So now you are Atecotomy width is 3 mm, isn't it?
But in this particular 3 mm may cause injury to the durameter, but it is not, the space is wide.
Okay, okay.
This is the tegmen antri, and in the tegmen antri the durameter has been opened, and this is the sinus tympani, sinus wall. It has also been opened, but towards the mastoid tip I am going.
So we can see the vertical facial, isn't?
Vertical
Vertical facial.
still not available. Posterior aspect. No ossicle is visible in the middle ear. ইয়েটা দেখি ওই ইয়েটা দেখি ওই এলিভেটরটা দিস ইজ এলিভেটর এই যে হাত দেখি Support is full now. Sucker cannot is full. এটা একটু 10 ম্যাগনিফিকেশনে করে দাও না 10 ম্যাগনিফিকেশন করে দাও না। হ্যাঁ 10 ম্যাগনিফিকেশন
অসিকেল বলছে নেই, ওখানে সাকশন করছে, ওখানে হেড অফ দি ম্যালিয়াসটা নড়ছে।
হয়েছে।
ওই দেখুন, ওই দেখুন, ওই দেখুন, দেখছে, ওই দেখুন বলছে
না
অসিকেল
ঠিক আছে ঠিক আছে ঠিক আছে,
দেখি
না আগেরটা করে দাও,
আইএস
আগেরটা হলো না ভালো করে ফোকাস। হ্যাঁ ঠিক আছে দেখো।
This is likely incus. Not in. This is likely malleus, not incus actually. But we have removed the tympanic membrane. Sir, can you sir focus the middle ear area?
Wait a little bit, wait.
Yes. This is good.
আচ্ছা তাহলে শুরু দিতে হবে না? শুরু।
Yes.
This is the malleus.
So the chorda tympani is in front of our view.
Yeah, this is the chorda tympani. Can you see the chorda tympani? This is the tympani
You
annulus.
can see the tympanic annulus and the chorda tympani.
Chorda tympani. This is the chorda tympani. Micro. Well, এটা adapter দাও।
Handle of malleus, because the chorda is going always behind the handle of malleus and above the incus. This is one important relations we have to keep in mind during dissections of this part.
ওটা দাও।
Sir, the juniors want to know what are your plans right now. We can see the mastoid antrum, we can see the ossicles, we can see the chorda tympani.
The ossicles, particularly malleus, is visible, but the incus is not visible.
Okay. So by lifting the chorda, you want to see the IS joint.
Trying to do so,
Okay.
but the chorda is also দেখি এটা দেখি, এটা রাখুন, এটা রাখুন।
Sir, please centralize the area. We cannot see the area of drilling.
না না না, ঠিক আছে ঠিক আছে, wait a little bit. কি দেখা যাচ্ছে?
Now we can see the head of the malleus. Is it, sir?
No, malleus is partially truncated.
Okay.
Head of the from the neck it has been cut, likely, already destroyed. अच्छा, एक घाटटा একটু ছোট আছে।
हाँ बट्टा और एक छोटा इसके इसका और एक छोटा साइज निकाल। नहीं नहीं ये सेम साइज है और एक छोटा साइज होगा। This is this one. দেখা যাচ্ছে? কি ডক্টর জানাম?
Hello, I am with you. Okay.
Here I will do a canal wall down.
Yes, yes,
But
yes.
before that, posterior.
I think now you can show the students the inside out approach. Just you retract the chorda tympani nerve and start drilling from that area. So they have also seen how it is inside approach is done. This is one option is there.
Here it is the posterior metal wall.
Yes,
It is the superior metal wall.
yes,
At the junction of the posterior superior metal wall, I will drill
yes, yes, yes.
so that I will open up the editors.
Yes.
Okay.
Okay. You can retract the corda because if the corda is injured, usually in this case, it is very difficult to save the corda. But still, we can
But
try.
still we can do. Doing the superficially. I am doing in the superficially. Then I will, at the final stage, I will use the diamond bar.
Before removing the canal, I think you should do epitemperotomy. You can start from the notch of the revenous. You can start. This is very good. For the juniors, if you start this was a small bar, if you start from the notch of revenous.
Here I am removing the bridge. Diamond bar. Diamond bar. Give it the diamond bar. The smaller diamond bar. Give the diamond bar. 1 or 2. Coda is still intact. And the coda is in my socket tip.
Yes. Can you show us the anterior and posterior buttress?
Anterior buttress is the posterior metal wall where it touches the tegmen. Posterior metal wall where it touches the tegmen, that is the anterior buttress. Posterior buttress is here. Floor of the external auditory canal touching the posterior metal wall lateral to the facial nerve, vertical part of the facial nerve. That is the posterior buttress. The bridge is being removed.
So can you show us the horizontal facial canal in the middle ear? Is it appreciable?
Wait a little bit. Wait a little bit. Fine adjustment ভেতরে ঢোকাও।
আপনি হয়ে গেলে আমাকে বলবেন আমি ফোকাস
Can you see the steppiece?
Yes, sir, yes.
Can you see the steppiece? Steppiece is here.
Okay, is it the suprastructure or the...
No, no, no. Steppiece is deformed. Wait, এটা probe.
We can now see the head of the steppiece.
I can see also the footplate of the steppiece. Already the footplate of the steppiece, there is displacement. Can you see? Here is the steppiece as a whole the steppiece.
And above that, is it the horizontal facial that we can see?
Likely. This is the horizontal facial canal.
Yes,
Fallopian
sir.
canal. This is the horizontal part of the fallopian canal. And I will drill this bone, that is the lowering of the facial ridge. Lowering of the facial ridge. Below. The sucker canal is we changed.
थोड़ा बड़ा कर दो আমি ফাইন ফোকাসটা করে দেবো শুধু আপনাকে বলবো যে
A diamond bar is there. Cutting bar.
कटिंग bar चाहिए कटिंग bar दो और कटिंग bar दो तुम छोटा वो बर सेट मुझे दो मैं देखो वो बता वो छोटा वाला दे दो हाँ वो सदीप सदीना को दिल से
Right. You can see the ridge, facial ridge. This is the facial ridge. This, the direction of the drill should be along the long axis of the facial nerve. Long axis of the facial nerve, here is the mastoid segment of the facial nerve. That should be like this one. Diamond bar. Diamond bar. Give a diamond bar.
वेंकट डायमंड बर दो वो छोटा वाला डायमंड द वन विच इज टू यस
Right, like this. Slowly. In the canal wall down procedure, you have to flush the ridge in such a way so that the floor of the middle layer, floor of the external artery canal, should be at should be flush with the floor of the mastoid antrum. Can it be seen? No, this is the vertical segment of the facial. Dr. Jana,
Hello, yes.
the
During the facial posterior canal wall,
posterior
that is the facial ridge.
the facial ridge,
Yes,
I am flushing
yes, yes, yes,
or lowering down,
yes, yes.
but I will also expose the vertical segment of the facial nerve for
Yes.
demonstration purpose.
The white structures, I think it may be the facial nerve. In the mastoid antrum,
This one.
yes, yes.
This one is the lower part of the vertical segment of the facial nerve,
It is already exposed.
already exposed.
Yes, yes.
But here you can see that the vertical part of the facial nerve, the course is slightly different. The course is more posterior.
Yes, 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 definitely. This is most posteriorly.
It should be towards the stalomastoid foramen.
Yes.
The stalomastoid foramen is like here.
So you can drill now.
Dr. Jana, what you are saying?
Yes, you drill a posterior canal wall.
No, I am lowering down the facial ridge.
Yes.
Facial lowering down for the canal wall down mastoidectomy.
Yes, yes, yes.
But for demonstration purpose, I am trying to expose the facial canal, vertical segment. Horizontal segment is here.
Yes. Can you see what is the position of the facial canal in the horizontal part with the probe, with the ballpoint probe?
Horizontal part of the facial nerve.
Yes.
Okay. Let's see. Probe. You can see this is the lateral semicircular canal, bulging. Can you see? Bulging of the lateral semicircular canal.
You can show the facial nerve canal, horizontal part.
Okay, and that vertical part of this lateral semicircular canal is just anterior to this lies the external genu, and this is the posterior semicircular canal which has been opened already. And this posterior semicircular canal is related to the...
Can you show the footplate of stapes area?
Which one?
Footplate of stapes area, the wall window area. The facial nerve is just above the wall window, posterior superior to the wall window. So if you see, you can see.
As because the stapes is already
you
displaced.
can show the wall window area. Then I think it is easy to locate the facial nerve.
फाइनल एडजस्टमेंट करो Can you see this structure? Dr. Jana?
Yes, 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 yes.
This is likely stapedius tendon. In the pyramid.
But I am not convinced with this. I think the white structure just, this is the facial fallopian canal.
No, this is the fallopian canal. This one is the fallopian canal. This one.
This one.
This one. This one.
Then you have the foot plate area.
But actually, the stapes has been displaced.
Okay, but you can see the oval window area. The facial nerve will just above and posterior to the oval window. This is the facial nerve. Yes,
find
that is the
adjustment.
facial nerve, I think.
Find adjustment.
And in the prominent area is like the promontory. What is the prominent
No,
area
final.
in the just field?
The promontory is like this area. This one.
Yes, this area is
This is the promontory. This
Yes.
is the oval window area.
This is the oval window area.
This is the oval window area. So above this oval window area, the foot plate of the horizontal part of the facial nerve is there. Wait. Yeah. Can you see the oval window area?
Yes, yes, yes.
Here is the oval window area.
Yes.
Oval in shape.
Yes, yes. Very fine. Very good.
And
We can see it clearly.
but keep it here. This is a diamond bar.
So, if facial nerve will be in the floor of the adidas. So, this is the, just above it is the floor.
Here was the editors. Editors has been opened
Yes.
as because the anterior pillar and posterior pillar has been removed.
Yes, yes, yes.
Still there is some bone.
This is the anterior buttress.
This-
This area is the anterior buttress. So the anterior buttress should be removed and it is flush with the anterior canal wall.
So that the anterior epitympanum being continuous
Yes,
with the
yes.
mesotympanum.
Yes, yes, yes. Sure.
The collar tympana is going medial to the malleus.
Yes.
Can you appreciate?
Yes, yes. Now you can see the head, I think that is the head of the malleus.
Malleus
Yes, yes,
was
yes.
a little lower down.
Yes, yes, that is the head of the malleus. That is the true epitympanum. You can focus it. Yes, yes, yes. That is, you can see now the head of the malleus. So the anterior buttress should be removed more. And then we can see the head and neck of the malleus.
Because the mastoid is too much contracted,
Yes.
the
All the anatomy is
all
distorted.
are distorted. Definitely.
garland is very, very sweet.
Dr. Jana, can you see
Yes.
the pyramid?
Yes, yes, yes.
Pyramid and stapedius tendon can be seen.
Pyramid and stapedius tendon.
Okay.
Which one?
देखिए probe डालो, probe. Focus करो, fine focus करो একটু. Here is the stapedius tendon. It can be appreciated or not. That is the
No,
stapedius.
yes, more, yes,
The
yes.
stapedius tendon.
Yes, the elevated area is the
Limited
most like
area,
that
and
is
this
pyramid.
is the pyramid. This is the pyramid.
But again, the pyramid is looking just below the level of facial nerve. How it can be? The pyramid actually is a projection from the facial canal.
No, it is just anterior to the vertical segment of the facial canal.
इसको 1.6 पे कर.
Mm-hmm. Okay, 10 times. No. No, go on. That is better. That is better. How to find focus करो.
Yes, it is lateral elevations with the muscle tissue attached to this. It may be pyramid, but then if there is the pyramid, then again this white structure will not be the facial nerve.
Usually, Dr. Jana,
Yes, yes,
see the quadratympanal nerve
yes.
usually exits from the facial nerve lower down, around about 6 millimeter above the stylomastoid foramen.
Yes, yes.
But here the quadratympanum is arising from the facial nerve higher up. This one is quadratympanum. This was the quadratympanum.
That is the stapedius tendon.
That is the stapedius tendon. What is it? Diamond bar.
देखो बेंगन स्ट्रक्चर. अभी पानी डालो.
Yes.
Give it to me, a cutting bar.
छोटा कटिंग बर. इधर छोटा.
Cutting bar दो.
We will advise to use diamond bar in the beginners in this case, in but this area.
I am using a cutting bar
Yes.
as because I have got the landmark of the posterior part of the horizontal part of the facial nerve and as well as the vertical segment here at the depth. So I am removing these of the cutting bar, and when I will finally reach the near the facial nerve At that time, diamond bar I will use.
पानी पानी
Yes. Yes, yes, yes. Especially for the beginners, it's diamond bar with so much irrigation. Yes. Diamond had the advantage that it injured the less chance of injury to the important structures. But disadvantage is that it generates more heat, so more irrigation is required. So thermal injury is more with diamond bar. Yes. Yes, 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 definitely. We should always try to use a large bar, as large as possible, without injuring the nearby structures.
Because Jana, in the same time, the facial now, when it is descending in the vertical segment of the facial now,
Yes.
here it is more coming superficially in the lower part.
Yes, yes, yes.
So you cannot expect the facial now in the same plane.
Yes, yeah. It becomes more lateral as it approaches towards the stylomastoid foramen.
Yeah.
The facial canal is exposed now.
Another thing, Dr. Jana,
Yes.
if I try posterior tympanal in this particular patient,
Yes, yes,
the
yes.
chance of facial injury is more.
Yes, yes, definitely, sure.
Give it to me, diamond bar.
डायमंड भर दे छोटा छोटा
Bigger one.
Yes. That is the round window coming into the view.
Yeah. Here is the codofacial angle.
Yes.
All the juniors are being acquainted with all types of complications
Yes.
in this particular specimen.
This is a particular specimen. Yes. So now we can see the round window.
वेंकट फेशियल नर्व एक्सपोज हो गया कौन सा सेगमेंट है ये? 1 second.
Can you see?
Yes, yes, yes. Very
The
fine,
fa-
good. Yes. The largest diamond bar. Yes. So what's the bar size? The question asked by one junior. Why not doing the particular this area?
Now, initially it was 3 mm,
3 mm. Okay.
but near the facial nerve,
Yes.
I am using a 1 mm. As
Yes.
because the facial canal, I am not exposing the whole of the circumference.
Yes.
The desired circumference should be exposed so that you can do the decompression of the nerve. There is a group of cell here. Can you
Yes.
see a cell?
Yes, yes, yes.
What is that cell? That
Like
cell,
perifacial cells.
perifacial, but in this situation, for the lateral semicircular canal, it is known as Herald cell.
Yes, yes, yes.
Herald. Can you see the external genu of the facial nerve?
Yes, clearly seen. Hello?
Here we can have the opportunity to see the relationship between the posterior semicircular canal and the facial nerve. This is very important because
Here is the posterior semicircular canal.
and the facial nerve is
And the
just
facial vertical segment
a vertical segment
of the
only
facial nerve, closely to the
only
posterior
few
semicircular canal.
millimeters.
Actually,
Okay.
the different semicircular canal ampulla is related to the facial nerve. The ampulla of the posterior semicircular canal is related to the vertical part. The ampulla of the lateral semicircular canal is related to the posterior part of the horizontal segment of the facial nerve. And the superior canal here is related to the labyrinthine segment of the facial nerve.
Right. This relation is very important, particularly when one is doing an sac decompression, where we really don't expose the facial nerve or we don't lower the facial ridge. But we expose the posterior semicircular canal and do a lot of drill around that.
There is another term of the facial nerve decompression that is known as barbar pulling of the facial nerve. Barbar pulling means on the vertical segment you have to explore from the posterior side. Then in the horizontal segment it should be from the posterior aspect. Here if I do the lateral aspect, then chance of chora tympani injury is more. And here if I do the superior aspect, then chance of injury to the lateral semicircular canal is more. And then in the anterior part of the horizontal segment, it should be on the inferior aspect. So the superior canal should not be injured. This is known as barbar pulling of the facial nerve. Wait a little bit. Can you differentiate between the sheath of the facial nerve and the actual structure of the facial nerve? Sheath of the facial nerve. Here it is the malleus. And if I want to expose the more anterior segment, we should cut the head of the malleus. Malleus is here. Malleus head is here. একটু ইয়ে করে দেখি না, আমি একটু হেভি দেখছি না না ফাইন অ্যাডজাস্টমেন্টটা করো, ফাইন অ্যাডজাস্টমেন্ট। ওটা তোমাদের ওখানে এলো? Is there any malleus nipper? Malleus nipper or any seizure?
চিংড়ি মাছের মালাইকারি, কচি পাঁঠার মাংস আর তোর চিতল মাছের পেটি।
Seizure, seizure, seizure. দেখি না, মাইক্রো সিজার হবে না, এমনি সিজার আছে। It is too much. Actually, the malleus head should be cut by malleus nipper. The malleus nipper is not available here. So for that reason, I am cutting the head of the malleus by scissor. Body, না কাটেনি। No, it is not cutting. Probe. Force দাও। ছোড়ো।
সাড়ে চারটায় অফ করতে, সাড়ে চারটায় অফ করতে হবে তো। প্রেসিডেন্ট স্যার, ইনস্ট্রাকশন আছে সাড়ে চারটায় অফ করতে হবে, মানে একটু পলিশ ওয়েতে বলি।
another point. Hey, focus করো।
Dissection within 4:30, so you have 15 more minutes. Please finish it.
দেখতে পাচ্ছ? ওয়েট ছাড়ো, ওইটা একটু ফাইন অ্যাডজাস্টমেন্ট করো। না, ইজি হবে না।
আমার নিয়ে যাচ্ছে,
একটু লিখে দাও।
থেকে মানে নিয়ে যাচ্ছে সব। স্যার বলবেন না স্যার কখন শেষ হবে?
না,
সাড়ে চারটা নিচে বললো সাড়ে চারটায় র্যাপ আপ করতে অফিস।
এইটা লুজ করো।
আমি বললে ঠিক হবে তো স্যার? আমি বললে ঠিক হবে তো? হ্যাঁ আপনি
ওয়েট হ্যাঁ, ঠিক আছে।
ছেলে
কি করলে আবার ইজি করে দিলে কেন? ওয়েট লিটল ওয়েট, ডাউন বার আছে।
দীপঙ্কর মোবাইল থেকে বললাম আপনি কানে কানে বলে আসুন।
এই সাকা সাকা
কে কোন রকম ভাবে অফেন্স নিয়ে নেয় বলা যায় না।
আর কতক্ষণ লাগবে মানে আমি আর কয়েকটা জিনিস ডেমনস্ট্রেট করে ছেড়ে দেবো। আচ্ছা আধা ঘন্টা কটা বাজলো কটা? আচ্ছা 4:30 অবধি রাখুন দেখি।
So sir, what we can see, you are drilling the anterior buttress.
Remaining part of the anterior buttress maximum portion has been removed.
Okay.
Remaining part of the anterior buttress I am removing. You can see the chorda tympani nerve.
Yes, we can see the chorda tympani.
Chorda tympani enter in the middle ear from the posterior canaliculus, then is going anteriorly and it will pass through the canal of huge ear.
Yes.
And you can see one particular nerve, lesser petrosal nerve, I am seeing, but I will demonstrate it. Here you can see there is a structure here. This is processus cochleaformis.
Okay, sir.
This is the processus cochleaformis. And
Sir, over the promontory we can see a neural structure. Is it the tympanic plexus that
Yeah.
you can see?
and that is the tympanic plexus
And the Jacobson's nerve.
and Jacobson nerve that is being continuous the lesser petrosal nerve. Lesser petrosal nerve, and it is going towards the processus cochleaformis. On the medial aspect of the processus cochleaformis, lesser petrosal nerve is going towards the roof, and then it will enter into the middle canal fossa. Ultimately, it will exit through the foramen ovale, and then will go to the auriculotemporal nerve. Can you appreciate the lesser petrosal or tympanic branch of the glossopharyngeal?
We can identify the Jacobson's nerve.
Here.
We can see the chorda tympani. Sir, for the sake of juniors, will you please kindly show us the anatomy of the middle ear, that is the round window, oval window, the round window niche area, the cibicularum ponticulus.
I have to lower down focus. Can you see the oval window?
Yes, sir, we can see the oval window. Yes.
Oval window.
Yes. Yes.
Ovaling the oval window is the
Facial nerve.
facial nerve.
Horizontal facial.
segment.
We can see the second genu. We can see the vertical facial as well.
This is the second genu.
Yes, sir.
And this one is the round window. Can you see the round window?
Yes, that is the round window niche.
That is the round window niche. This is the caudal eminence. Chorda tympani nerve is going, so that it will it will divide the posterior tympanum into two parts. One is sinus tympani, lower down. Here is the sinus tympani, and this is the posterior tympanic sinus. Posterior tympanic sinus. And then you can easily see this is the promontory area, and the tympanic branch of the glossopharyngeal nerve is here. Can you see? White structure.
That is probably an ossicle. Is it?
Likely remnant of the ossicle.
একটা অ্যালিগেটর ফসেট দেন না স্যার ওটা বের করে দাও।
Actually, likely this is a stapes. The step is superstructure.
Incus.
Oh, sorry. Sorry, this is the incus. But incus has been eroded in different areas. This is the incus is eroded in different areas. চল probe. This area is the likely geniculate ganglion area. Here is the process cochleoformis. Just above the process cochleoformis is the geniculate ganglion area. And this is the labyrinthine segment of the facial nerve.
Yes, sir, we can see that. From where the GSPN arise.
দাও অফিসটা কটা অবধি একটু
Sir, will you please remove the remnant of the tympanic membrane so that the middle ear can be more convincingly visible to us?
Dr. Das, what you have said?
So the audience want to see the structures of the middle ear. So if you remove the remnant of the tympanic membrane, then the middle ear will be more widely exposed.
Elevator.
Sikil nai kimbada ye de alligator.
Here also you can observe that the facial nerve is almost over the oval window. So particularly there is the indication of stapes when the facial nerve is over the oval window. Cannot do the stapedectomy.
Definitely it is overhanging over the oval window.
Ekdom. Just you can see some niche of the oval window, but not the full. The oval window is not seen clearly.
Yes, now the middle ear is.
Actually, elevator is not available. Elevator though. Curate. No, curate no, elevator though. Elevator though. Elevator, अच्छा.
This structure? No. The remnant of tympanic membrane, yes.
But it is not elevating easily like a living body.
Yes. Tympanosclerotic patch. Yes.
This area is the hypotympanum.
Hypotympanum, yes.
The round window.
Yes.
This is the subiculum.
Yes.
And oval window.
This is the ponticulus.
This is the ponticulus.
Yes.
And in between the ponticulus and the subiculum,
It is the sinus tympani area.
Medial to the facial nerve is the sinus tympani.
Yes. So very finely, very nicely, the facial nerve has been exposed and decompressed. Yes, we can see the round window. Again.
No, actually, Dr. Jana,
Yes,
for decompression of the facial nerve, the sheath should be cut open.
yes, yes.
Facial nerve
In
sheath,
some or sometimes I think the seat already has been opened.
partly sheath has
Partly,
been
yes, yes.
detached.
Ah. ওদেরকে বাঁধিয়ে দেবে। Yes.
Can you see the fallopian canal margin?
Yes, 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 yes.
If you want to reroute the facial nerve, then you have to expose this area
Yes.
and this area. Then you can reroute. Rerouting of the facial nerve.
So can you show the lateral semicircular canal and the facial nerve, the relations of them?
Here is the lateral semicircular canal.
Yes, yes, yes.
Dome.
This is the lateral semicircular.
But
Yes.
if I expose this area,
Yes.
I will get the within the canal, lateral
Yes.
semicircular canal, that is the ampoule of the lateral semicircular canal.
Yes.
And these areas should be drilled for exposure of the endolymphatic sac. This is the
Endolymphatic sac.
endolymphatic sac is not visible here, but if
Yes.
I want to remove this plate of bone
Yes, yes, yes.
in front of the lateral sinus, but behind the retrofacial cells, inferior to the posterior semicircular canal and above the jugular valve. This is the area where the where the endolymphatic sac in the posterior canal fossa dura will lie there. Can you understand?
So, sir, for the juniors, can you show the Donaldson line?
Here is the lateral semicircular canal,
Yes.
and if I draw a line here along the long axis of the lateral semicircular canal, which will bisect the posterior semicircular canal, along the long axis of the lateral semicircular canal, which will bisect the posterior semicircular canal and touch the lateral sinus, is the Donaldson line, and the the endolymphatic sac will lie lower down this Donaldson line always.
Okay.
If I expose this area, then the endolymphatic sac we can get. Small, you know.
Thank you, sir, for the excellent demonstration of the dissection. We are running short of time because this place, the place where we are having this dissection, this has a time period and they are about to close. The scheduled time for closing is 4:30. It's a Saturday. It is long beyond their working hours, but still we are stretching them. So no thanks is enough for Dr. Professor Subroto Mukhopadhyay for showing us this excellent demonstration, and we are thankful to him. We are really grateful that he took out time from his busy schedule and came to us. So
If I want to, Dr. Das,
yes, sir.
if I want to do labyrinthectomy, then we have to enlarge this posterior semicircular canal,
Yes, sir.
and we have to enlarge this lateral semicircular canal. Posterior semicircular canal will unite with the non-ampullary end of the superior semicircular canal here.
Yes.
That is the area crus commune. And from the crus commune we will get entry into the vestibule. And
Yes, sir.
from vestibule, on the medial aspect of the vestibule, there is spherical recess and the elliptical recess. And on the medial aspect of the elliptical recess, we will go inside the internal auditory canal. But we have to drill too much.
Yes, everybody has a fairly good idea now because of the excellent dissection you have shown, that where we can drill for the labyrinthectomy, and we can already delineate the posterior semicircular canal, and we know the place of the lateral semicircular canal and probably the superior semicircular canal also. So I think because of the paucity of time, we won't proceed with further labyrinthectomy because it will take much time, and we don't have that time now. So thank you, sir, for showing us the excellent dissection.
Yeah.
I am sure that all the postgraduate students who are assembled here, they have gained a lot of experience by seeing
one of the greatest stalwarts of otology, operate before them.
आंटी छोटो বার আছে ছোট বার
Hello. So today's competition for the junior category result. Before the declaring the result, the otoscope for the second and first prize. নিচে আছে প্রিয়া নিয়ে আসো না না আছে এই থাক 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 স্যার সেকেন্ড দুজনকে এটা টোকেন প্রাইজ দেওয়া হবে তো ফার্স্টকে তো গোল্ড মেডেল সে তো কনফারেন্সের সময় ও খায়নি কিন্তু খায়নি ওকে খেতে বললাম খায়নি নিচে ওখানে রাখা আছে অফিসে রাখা আছে খাবার
এবার বলি
খেয়েছিস তো স্যার
Okay, I am stopping. Can you see the cross commune? Here is the cross commune. Okay, I am leaving now. Okay.
Thank you.
কিন্তু যা করলাম
হ্যালো আসছেন
বন্ধ করো না
So good afternoon for the junior category. First, Dr. Archira Mirda. Second, Dr. Kuldeep Acharya. Dr. Kuldeep Acharya.
In a big way, Sanofi will participate around 60 lakhs for the conference. Please give them a big round of applause.
Thank you, Doctor. Thank you for your kind words, and really I appreciate the way you all are helping Sanofi in long way. That is really going to help us in longer run. See, Sanofi believes into the scientific connect with all the doctors, and this program is also in continuation with that. Most of the times we are connecting with all of you in continuation with the scientific activities or any conferences. See, the upcoming conferences are really important for all of you and including us, because you all are completely driven by science. Like today, they are hands-on. This is really great. Very few places the doctors are getting hands-on support. So the way you all have supported to all the clinician and the doctor, really it is going to help us. So we are there with you. Though sir has already conveyed that we are going to participate. In what way, that will come back to you after discussing with the marketing. But definitely we are going to participate into this. So thank you very much for helping us and allowing us to be the part of such kind of the scientific events. Thank you very much. Thanks a lot. And thank you, sir.
Thank you, Sanofi, for your participation. And okay. So they have been taking part in us all our academic endeavors all throughout, and more so in the recent years. And we believe that whatever Snehashish has just pronounced, it's just a number, but then it's important for us to be able to sail through the conference very successfully. And obviously it will be accepted by all of us. Thank you.
And thank you, Sanofi. And this is the 18th. In 2008, we started, and from the very first day, Sanofi is with us with this temporal bone dissection course. And really, and every year, even last year and every year, they used to come. You used to come with us, and we could organize this temporal bone dissection very nicely. Much for the contributions also. And so I'll request that this program will go on. It will not stop. Yeah, and please be there. And of course, you all know that you will be doing in a very big way because it is our all prestige conference in 2026. So thank you.